Good afternoon, everyone. A warm welcome to all the participants joining us live for today's exclusive health webinar hosted by Onus Robotic Hospitals. Our topic today is obesity and heart disease, a highly relevant discussion in today's world where lifestyle and health are deeply intertwined. I'm your host for today's session. I'm delighted to introduce our esteemed speaker, Dr. Vinod Vadthya, Senior Consultant, Interventional Cardiologist, and Head of the Cardiology Department at Onus Heart Institute. He is a leading expert in interventional cardiology with vast experience in treating complex cardiac conditions, performing angioplasties, and promoting preventive health care and also heart care. Doctor, it's an honor to have you with us today. Feel free to drop your questions in the chat box. Viewers, please make sure on that. And Doctor, the screen is all yours. Please go ahead, sir.
Thank you, Sai. Thank you. Yeah, today after heart attacks, burning topic is obesity and heart disease. So at our Onus Robotic Hospitals, what we are going to do with heart disease patients when patients comes with overweight, obesity, what we call as morbid obesity. So here I'm going to give you current updates and what in this AI generated era, what we are going to do. So here, so what is the global burden? So 1 billion adults overweight are there, more than 650 million obese according to WHO 2025, and obesity prevalence is more than 40% increases since 1990. And coming to India, urban obesity more than 27%, rural 11%. So 2 in 3 deaths related to high BMI, which leads to cardiovascular deaths, according to ESC 2025 consensus. So what about obesity, heart disease at a glance? How we are going to divide today? So 1 billion affected worldwide, mechanism of inflammation, insulin resistance, and what are the therapy, GLP-1 agonist and lifestyles and surgery, and weight reduction, CVD risk will decrease by that. So what is the definition of obesity? So obesity is a state of excess adipose tissue in the body, which medically meaningful distinction between lean and obesity, it's arbitrary. So obesity is defined by assessing its linkage to morbidity and mortality. So here, obesity causes excess calorie intake, physical inactivity, which leads to health consequences like diabetes and cardiovascular disease, which leads to a lot of interventions we need to do. So what are the causes of overweight and obesity? Whether genetic does it play a role in obesity? Yeah, we can say. However, in most cases, both genes and behavior are necessary for a person to be overweight. So body weight is a result of combination of influences like genetic, metabolic, behavioral, and environmental, cultural, socioeconomic influences. So therefore, behavioral and environmental factors provide greatest opportunity for action and intervention. So what are the methods to measure adiposity? So body mass index, anthropometry, CT, MRI, electrical impedance. So assessment of obesity, we can measure with waist circumference. So more than above 40 inch in men, 35-inch women is called as health risk, which leads to obesity. So BMI, how to calculate the BMI? Weight in kilos divided by height in meters square. So most large-scale epidemiological studies says that all-cause metabolic, cancer, cardiovascular morbidity begin to rise when BMI increases more than 25. So here NHLBI technology says that so underweight less than 18.5 kg per meter square, normal 18.5 to 24.9, overweight more than 25 to in between 29.9. We can call it as a pre-obese. So obesity class 1, 30 to 34.9, obesity class 2, 35 to 39.9, obesity class 3, more than 40. So this is the BMI levels where we are stands to, in this era. So we need to check our BMI and what to do, what modification need to do in our lifestyle. So what is the classical risk factors for cardiac diseases? So diabetes, smoking, hypertension, dyslipidemia, obesity, lack of exercise. Other than this, nowadays, stress is the most common classical risk factors now. And
Yes, doctor, exactly.
yes, and food intake, where we are taking junk foods nowadays. We are not eating quality foods. So a lot of adulterated food we are taking nowadays. So obesity and overweight increases the risk of hypertension, stroke, diabetes, metabolic syndrome, cardiovascular mortality, cancer related like endometrial, breast, prostate, colon, and gallbladder diseases, osteoarthritis, respiratory disease and sleep apnea. Last one, so we can see when patient develops morbid obesity, unable to sleep, when patient unable to take breathing also, this is called as sleep apnea. So how does obesity causes cardiovascular disease? Obesity, metabolic disorder, this is an interlinked chain. So age, gender, mechanism. So here you can see what is the pattern of body distribution where fat accumulates. First, look at men one side, female one side. Intra-abdominal or visceral type, we can say this is like android apple shape in men, sorry. In women's comes to pear shape. So lower body fat distribution, external type. So we can call it gynoid or pear shaped fat distribution. So visceral type distribution here normal. Here you can say all fat distribution in the city. So body fat distribution, men are adopt to develop visceral type of obesity while women develop peripheral type. So androgens appear to influence this distribution. So PCOS with androgenemia predisposed to visceral type obesity, and corticosteroids and growth hormone intake also tend to develop visceral obesity. So how does obesity causes cardiovascular disease? So abdominal obesity, where the deep visceral fat embedded in there, and lipolysis, which is insensitive to insulin. So when the body having insulin, but that insulin not reacting to the whatever the stored glucose. So insulin should be react to that, and at the time of uh, glucose should be reduced. So this leads to free fatty acids and muscle, pancreas, insulin resistance, metabolic syndrome, diabetes, liver gluconeogenesis, increase triglycerides, LDL, decrease HDL, and blood vessels, hypertension, hypercoagulable states, endothelial dysfunctions, which leads to cardiovascular disease. So here you can see adipocytes, factors released by these adipocytes that can affect the peripheral tissue. Hormones like energy, this leptin, which balances energy, and adiponectin, and resistin. Adiponectin, which is derived from adipose tissue, which decreases the obesity and enhances the insulin sensitivity and oxidation it can occur. So these levels, hormonal levels will be decreased. Cytokines, so TNF alpha, IL-6, and substances like free fatty acids and glycerol, and complementary factors DA, adipsin, others factor PAI1 and angiotensin, RBP4, enzymes, aromatase. So these all factors will be released by adipocytes, which imbalances our body and leads to obesity. So obesity and insulin resistance. This is the most common where we are going to face insulin metabolic syndrome is insulin resistance. Here, hyperinsulinemia will be there, hyperglycemia, sugar levels will be higher side, which leads to activation of sympathetic nervous system, which increases the arterial tone and sodium reabsorption, which leads to hypertension. And overstimulation of the pancreatic beta cell, a reduction of the insulin secretion, so leads to type 2 diabetes. So one side hypertension, another side diabetes. So the insulin resistance syndrome is a physiological response. It is inadequate for the amount of insulin secreted. So metabolic syndrome associated with the insulin, here you can see. Already we have discussed endothelial dysfunction, systemic inflammation, everything we have discussed now.
Yeah.
Yeah. So what are the clinical manifestations of insulin resistance syndrome? Central obesity, glucose intolerance, atherosclerosis, hypertension, polycystic ovarian syndrome, biochemical abnormalities like carbohydrates, insulin resistance, hyperinsulinemia, lipids, high TG, LDL-C low, small, dense LDL-C higher side, and fibrinolysis increase or thrombosis and atherosclerosis. So insulin resistance and heart disease, diabetes, hypertension, low HDL, high TG, same what we have discussed, which leads to endothelial dysfunction and LVH, left ventricular hypertrophy, increased C-reactive proteins. Here, obesity, metabolic derangements, insulin resistance, dyslipidemia, sleep apnea, inflammation, endothelial dysfunction, cardiovascular diseases. So pathophysiology, adipose tissue dysfunction, insulin resistance, inflammation, dyslipidemia, vascular injury, endothelial and atherosclerosis, cardiovascular disease. So same hypertension, increased blood volume, obesity, cardiomyopathy, cardiac dilatation, diastolic dysfunction, heart failure. So most of the obesity patients will be having, in women's, there will be heart failure with preserved ejection fraction. There won't be any heart pumping issues. Heart pumping will be preserved, but because of diastolic dysfunction, because of this, heart leads to failure conditions. So obesity, heart failure. Obesity risk factors leads to structural and functional abnormality, leads to heart failure. So obesity and heart failure is a heart failure with preserved ejection fraction. Weight loss improves the diastolic dysfunction. According to ACC 2025, target BMI is less than 25 kg per meter square in heart failure with preserved ejection fraction. So symptoms will be decreased, weight reduction should be there. So obesity and arrhythmias. So when it comes to heart disease, arrhythmias, among arrhythmias, atrial fibrillation is the most common, which increases the risk more than 40% per 5 BMI units increases and leads to obstructive sleep apnea, which amplifies the risk also. So weight loss is the ultimate to decrease atrial fibrillation and recurrence and post-ablation therapies also. So obesity and coronary artery disease, early endothelial injury, which leads to plaque formation, chronic inflammation, which sustains atheroma, plaque ruptures, and which leads to heart attacks. So weight loss is ultimate goal here. It will decrease HSCRP and carotid IMT also decrease. So what are the risk factors for metabolic syndrome? According to ATP3 guidelines. So here, which is called as metabolic syndrome, abdominal obesity, men more than 1 or 2 centimeters, women more than 88 centimeters waist circumference, triglycerides more than 150, HDLC less than 40, women less than 50, blood pressure more than 130 by 85, fasting glucose more than 110. So among three, metabolic syndrome is 3 or more than, so it leads to all of us. So what are the goals for management of metabolic syndrome? So opportunity to prevent predictable complications like diabetes and cardiovascular disease. So management, so weight loss is the main. Proper diet, exercise are the obvious recommendations. Drug therapies like insulin sensitizers, which leads to a decrease in hyperglycemia. Statins, correction of the raised LDL. Niacin for decreased LDL, HDL cholesterols. Fibrates and omega-3 fatty acids for elevated triglycerides. So what about obesity and hypertension link? How hypertension occurs in obesity? Here obesity, 70% of the hypertension in men and 60% in women because of extra adipose tissue deposition. So hypertension, insulin resistant hyperinsulinemia, activation of sympathetic nervous system, which leads to vasoconstriction, increased cardiac output, and increased sodium reabsorption, leads to increased blood pressure. So volume overload will be there, then leads to blood pressure's higher side. So here is a mechanism which causes hypertension, renal dysfunction. Here, obesity leads to renal medullary compression and increased renin-angiotensin and sympathetic nervous system activity, increased tubular sodium reabsorption, volume expansion, arterial hypertension, which leads to glomerulosclerosis. On the other side, renal vasodilation leads to glomerular hypertension. And lipids will be higher side, glomerular sclerosis. Glucose intolerance, increased glucose. Here, all in one: visceral obesity, sodium expansion, heart rate, endothelial dysfunction, diabetes mellitus, dyslipidemia, atherosclerosis, arterial resistance, increased cardiac output, hypertension. Eccentric hypertrophy, concentric hypertrophy, both will be there in obesity. So which leads to congestive heart failure, coronary artery disease, sudden cardiac deaths. Coming to women with obesity. Here you can see most of the women suffering with PCOD symptoms. And those women with postmenopausal group, there will be increased visceral fat, which lead to hormonal imbalance. So in females, greater heart failure with preserved ejection fraction burden will be there. So most of the women's underdiagnosed, undertreated. Why? Because they are not exposed to outer society. So most of the females will be underdiagnosed and undertreated. So what are the health benefits of modest weight loss? So possible, which decreases the risk of death, decrease the cardiac risk, MI rates, stroke rates, improve serum lipids, improve prognosis in type 2 diabetes, decrease glucose and insulin levels will increase. Can significantly reduce the sleep apnea, osteoarthritis, bone problems will be reduced, reduces the relapse rate of asthma. So modest weight loss, minimum of 5 lbs we need to do. So what are the actions and adverse effects of weight loss agents? These are the weight loss drugs are there. Dexfenfuramine, serotonin release agonist, which adds on a valvular heart disease. Fenfluramine, these are furamine groups. So these two same valvular and serotonin releasing agents. Sibutramine, which is a serotonin norepinephrine reuptake inhibitors, so it increases the heart rate and blood pressures. Orlistat, it inhibits the pancreatic lipase, decreases the fat absorption. So soft stools, anal leakage, decrease in absorption of the fat soluble vitamins. So what are the GLP-1 agonist and dual agonist? So this is the main treatment according to our new guidelines. Semaglutide and tirzepatide more than 20% weight loss, and it decreases the major MACE by 15% in select trials, recommended as a first line for obesity with cardiovascular disease. What is the lifestyle? Dash and Mediterranean diets will be maintained. More than 150 minutes per week, moderate activity of walking should be there. Behavioral therapies, sleep optimization, diet, exercise need to do. Bariatric and metabolic surgeries. So nowadays people are very much fancy about bariatric surgeries when we are not
Yes, yes,
able to reduce our body weight. So initially we need
yes,
to go for lifestyle modification.
yes,
So
doctor.
once your lifestyle modification, food habits we need to change, and weight reduction therapies will be there. After completion of this, even though you have tried a lot, not able to achieve your goals, and your BMI is more than 35 kg with cardiovascular risk is there. In patients with more than 40 kg per meter square without comorbidities, we can go for bariatric surgeries. So bariatric surgeries, there are pros and cons are there, complications are there, and weight reduction will be 60 to 70% of the excess weight will be reduced with bariatric surgeries. So there are modalities, 4 5 surgeries are there, but there are complications related to early, during and post complications, late complications are there. So these complications should be managed very properly, and we can save the life. So what is the management here? Reduce the calorie diet we can take. High calorie diet should be avoided. So energy intake 500 to 1000 kilocalories per day to achieve the weight loss of 1 to 2 lbs per weeks over 6 month period. So never go for a short term goal. Don't think of that. Don't stop your food, and increase your activity. Start with 30 to 45 minutes moderate activity, 3 to 5 days per a week, and work up at least 30 minutes moderate intensity physical activity on most all days per week. So what is a behavioral modification? Use multiple behavioral strategies like self monitoring of eating habits and physical activities. Like we won't monitor like small foods in between we are eating, but we are not calculating the calories. So what is surgery? I have discussed with surgery. Class 3 obesity patients, we can go for class 3 means more than 40 BMI.
Yeah,
So a class 2 obesity, 35 with comorbid conditions. So we need to go with those. So other treatments have failed like lifestyle and whatever your calorie diet,
yes,
increase activity, behavioral, all
yes,
these
yes.
we tried, then go for surgery. So recent guidelines says that treat obesity as a major primary cardiovascular disease risk factor. Weight reduction more than 10% improves cardiovascular outcomes. Early use of GLP-1 and dual agonist, and integrate cardiometabolic teams like it is a approachable one, uh, uh, multimodality treatment unit. Not one person should manage in these patients. So physician, cardiac and surgeon should be three team approach should be there to monitor these patients. So EAC 2025 consensus says that 67% of the high BMI deaths are due to CVDs, and screen every CVD patient for obesity. Weight loss improves your blood pressure, decreases lipids, improves your LV functions. So World Heart Federation says that obesity, which leads to fastest growing driver of CVD globally, rising in young age groups, stigma and bias, missed the treatment. Obesity is heart disease in slow motion. Thank you.
Thank you, doctor. Thank you so much uh, for the truly insightful session. You have beautifully explained how obesity directly impacts heart health, from cholesterol imbalance to increased blood pressure, and how lifestyle modifications can prevent cardiac risks. And I too feel my personally being a too weight and overweight, I too feel this is a good session for me, and my thoughts were vanished after listening all instructions from you, doctor. Thank you so much. And doctor, now Let's open the floor for some audience questions. So here are some questions our audience were pinged here. The questions were that the question number one was the ideal BMI body mass index to maintain for a healthy heart.
Yeah, definitely we need to maintain. So more than 25 is a higher side, which leads to obesity. So overweight, always we should neglect. We should decrease
Yes,
overweight. 25, below 25, we should ideally maintain.
yes, doctor. Yes, yes. Thank you. One more question there. Can obesity related heart damage be reversed with weight loss or like?
Yeah, we have discussed heart damage. Obesity leads to adipose tissue deposition, which leads to sympathetic uh, stimulation and increases our hypertension levels. BP levels will be increased and plaque deposition, atherosclerosis will be there. So this will be little bit lower side. When patient decreases the weight, automatically his blood pressure will be lower side, and this will be reversible. Not completely we can say, but there are the chances of reversible much more.
Yep, yep. So, doctor, and what are some simple steps to start weight management safely? We need some instructions from you.
Yeah, definitely. Uh, Patients with whatever the weight, we feel that excess weight or confidence levels, not only the weight. So your
Yes, yes,
weight
yes,
leads your confidence. So you
yes,
need to maintain your confidence means you need to put on your confidence levels with optimum weight. So for that, we need to start with regular. Main thing is that you should wake up at 4 o'clock or 5 o'clock. Early morning wake up should be there. You should see the sunrise always, and then the nature will helps us how to improve our body weight, how to decrease our body lifestyle modification. So go for when patient starting stages, like you're not going for any walk nowadays, then you need to start by baby step, teeny steps. We need to go for small walks, 10 minutes, 15 minutes. You can increase your stamina and go for half an hour daily. And meanwhile you need to monitor your food intake, not only exercise and lifestyle modification. Food intake should be monitored properly. Like you should not take heavy calories, we should be avoided. Oily food we should avoid, and deep fry items like dosa and like vada, whatever those nowadays puri available, and avoid all junk foods like fried foods we need to avoid. So and take vegetables, fruit salads, decrease salt in your diet. So this will automatically decrease your weight. And one more thing is that you need to stop rice intake at night time. So stop rice intake, go for chapatis, or you need to titrate it like in the way
yes,
like chapatis or fruits we can. So I can't say that you need to stop the diet midnight completely. Night food you should not stop it. So step by step,
yes, yes.
everything will be step by step. So this thing we should maintain, and we can optimum our weight.
Yeah, yes. That sounds great, doctor. Doctor, last question. How often should one undergo cardiac screening if they are overweight?
Yeah. So when overweight is there, uh, we need to check like whether any risk factors are there other than overweight, whether we are developing any hypertension, whether we are under any pre-diabetes stage, or so once without we don't know about our health, we are healthy. We feel that we are healthy, but overweight is there. So at this point, we go for checkups for 6 months at least. If we are having any risk factors, comorbid conditions, then we need to follow according to. Like hypertension, we need to monitor regularly,
Yes,
monthly or uh, 3 months once. Diabetes
yes,
every
yes.
third month we need to do. So according to that, we need to modify.
Yeah. Thank you, doctor, for those detailed and practical answers. I'm sure our youths have gained valuable knowledge today, and myself also. And guys and viewers, before you leave, please take a minute to fill out our short feedback survey. Your responses help us bringing your more informative sessions like this one. The survey link will be shared in the chat box. Please do fill it out before logging off. Thank you once again to Doctor and to all viewers for joining us. Stay connected with us, Onus Robotic Hospitals, for more education and health awareness program. This is your host, Sakiran Tate, signing off. Stay safe, stay healthy, and keep your heart smiling. Thank you, doctor.
Thank you. Thank you. Thank you.